Uh, Sir, this is Dr. Mahjbi. I'm ex-fellow neonatology from the Rajab Tayyib Erdogan Hospital, the one of the Indus Hospital, Fargad, and I have done my FCPS neonatology recently, Alhamdulillah. And I have also done my FCPS Peds medicine from Children Hospital Multan, and I have done my graduation from Army Medical College, Rawalpindi, under the National University of Science and Technology.
The Army Medical College. I graduated in 2005. Currently, I am professor of pediatrics at Military Hospital, Rawalpindi, and I am a consultant neonatologist. I did my FCPS in pediatrics in 2013, and then did my FCPS in neonatology in 2018. Then after that, I did my MCPS in health profession education in 2022, sir.
Okay, I think we can get formally started. Before we move forward, I want to make sure that we are all muted. You don't want us to hear your in-house secrets, right? So make sure you are muted. You have the option to ask question. If you have to ask question, you can unmute yourself. You can also ask question in the chat box, which we will review in the end.
Thank you, sir. So this is Dr. Mahjbi, and today the topic of my discussion is neonatal golden hour. And we are going to discuss very important topic, golden hour management, and we have a very comprehensive review on this topic. So this is my hospital. Sir, this is my hospital, Fargar. This is not less than a pearl for the in the desert, and providing quality care free of cost and paperless hospital in the South Punjab in this area. And I did my training from this hospital under the supervision of Dr. Athar Razak. He is my mentor throughout whole journey of my training and also my passing the exam. And Sir is also present on this forum. And now I would like to discuss a very comprehensive review on this topic. Sir, first of all, what is the golden hour management? It is the evidence-based intervention during the first 60 minutes of postnatal life to better support the fetal to neonatal transition, leading to better short-term and long-term outcomes, particularly in extremely preterm, extremely low birth weight, and very low birth weight infants. Evidence-based intervention address pre-delivery planning, delivery room management, and these evidence-based intervention can significantly reduce morbidity and mortality in this fragile group of infants. What are the objectives of this review? The objective of the review is to summarize the best practices in the management of extremely preterm infants during the golden hour, and to review available evidence from QI initiatives and studies showing the impact outcome like bronchopulmonary dysplasia, intraventricular hemorrhage, retinopathy of prematurity, hypothermia, and hypoglycemia. Here are some key points. The golden hour is first adopted from the adult trauma literature in 2009 by Reynolds et al. In neonatology. Published literature shows a consistent benefit in establishing a golden hour protocol, improving short-term and long-term outcomes. This concept includes evidence-based interventions during the first 60 minutes of postnatal life to better support the fetal to neonatal transition. Despite recommendations from the International Liaison Committee on Resuscitation IL-Core and evidence for improved outcome with standardized golden hour practices, recent surveys highlight persistent variability in the care within the first 60 minutes of life provided to the vulnerable population. And why there is a need for golden hour management? What's its purpose? We all know prematurity is the leading cause of neonatal mortality and 50% of childhood disabilities in the United States of America, and more than that in our countries. Extremely premature babies who are less than 27 weeks of gestation and extremely low birth weight who are less than 1,000 gram, premature and extreme low birth weight infants mortality rate are 30 to 50%. This data is of United States of America. Resuscitation in the delivery room and stabilization during a neonatal ICU admission involves a series of interdependent tasks, procedures that must be done efficiently and systematically for better outcome of these babies. Due to the complexity of the care required at birth, protocols, including evidence-based practices with standardized application in the first 60 minutes of life, have been applied to improve the quality and ensure the consistency of care for extreme premature, extreme low birth weight infants. And here are some key points of golden hour management. What should we do for the in the golden hour in first 60 minutes of postnatal life? Pre-delivery counseling, literally I will describe one by one. Delivery room management, discussion, and assigning the role for team members, in which we make a team and we assign the role. One is the team lead and other are participants, and preparation of the necessary equipments before delivery. And equipment check should be done as we do in the routine neonatal resuscitation program workshops, delayed cord clamping, and the prevention of hypothermia, prevention of hypoglycemia, continuous positive airway pressure therapy, and early surfactant administration through INSURE method. And pre-delivery planning, it includes antenatal counseling, role assigning for team members, and equipment checklist. It is the antenatal counseling and the antenatal counseling was first introduced in the NRP algorithm in 2015. It is the critical before delivery of extreme premature, extreme low birth weight infants. The team lead, who may be the neonatal fellow in the academic settings or other trained person, should meet with the parents to counsel them on the outcomes, potential short-term, long-term complications related to extreme prematurity, and anticipated neonatal course should be explained to the parents. It results in the reduction in the parental anxiety and also decreases the stress and increase the parental satisfaction. And also a shared decision-making approach should be utilized for all these deliveries. Additional communication with the obstetric team is also very important in preparing for such deliveries. And this is assigning role for the team. This is also very important. Delivery room teamwork, communication for the management of extreme low birth weight infants. The neonatal resuscitation team lead should facilitate pre-delivery difficulties to discuss any significant antenatal history and assign role and responsibilities for team members. And whenever delivery is expected, required delivery room equipment should be checked and prepared. And other one is delayed cord clamping. As you all know, the neonatal resuscitation program revises that cord clamping should be done after 30 seconds to 3 minutes, 30 seconds to 180 seconds. And the total amount of whole blood in the fetal placental circulation, as you all know, is 110 to 115 ml per kg of fetal body weight. And about 30 ml per kg is residing in the placenta. And if we do the delayed cord clamping as compared to those babies whose cord clamping is done early, results in few RBCs transfusion and decrease the need of RBCs transfusion, also decreases the risk of intraventricular hemorrhage and also decreases the risk of necrotizing enterocolitis. While milking before 32 weeks is not allowed because it induces the intraventricular hemorrhage in this vulnerable age group. And after that, we have to prevent the hypothermia in these babies. You all know there are 4 mechanisms by which baby loses the heat. The first of all is conduction, second is convection, third one is radiation, and fourth is evaporation. And why baby got hypothermic who are extremely premature and extremely low birth weight babies? Because there is a large body surface area to body mass ratio, very large area of head, and there are decreased subcutaneous fat, low levels of 5,3 monodeiodinase, low range of thyrotropin, and lack of shivering thermogenesis, due to which baby got hypothermic. And here are recommendations to prevent hypothermia. The American Academy of Pediatrics and American College of Pediatrics says to maintain an auxiliary temperature of approximately 36.5 degrees centigrade for newborns, and the delivery room temperature should be between 75 to 79 degree Fahrenheit. The World Health Organization advocates maintaining temperature in the delivery room at 25 to 28 degrees centigrade or 77 to 82 degree Fahrenheit. The 2015 IL-CORE International Liaison Committee on Resuscitation recommendation is to maintain an environmental temperature for a newborn, non-asphyxiated infants born less than 32 weeks of gestation should be between 23 and 25 degrees centigrade or 73 to 77 degree Fahrenheit. And the European resuscitation guideline recommend keeping the delivery room temperature between 23 to 25 degrees centigrade for babies at least 28 weeks of gestation and more than 25 degrees centigrade for preterm infants less than 28 weeks of gestation. This is how we will prevent the hypothermia by providing polyethylene bags and by providing the incubator care, by pre-warming the warmer, preheating the warmers, and these all measures can prevent the hypothermia in our babies. Polyethylene bags versus wrap. International Liaison Committee on Resuscitation recommends placing extremely premature neonates immediately after birth in polyethylene plastic wraps or vinyl bags without drying. And the baby should be covered with a cap also. All resuscitation procedures should be performed while the infant is in the plastic bag, including intubation and umbilical catheterization should also be done when the baby is in the plastic bag. These bags can significantly decrease the hypothermia and also same time increases the incidence of hyperthermia in extremely premature and extremely low birth weight infants. Total body wrapping was comparable to covering the body up to the shoulders in preventing the postnatal thermal losses in very preterm infants. One analysis concluded that uses of polyethylene plastic bags immediately after birth prevent one case of hypothermia for every 6 wrapped infants. Monitoring for hyperthermia should also be done, as I already mentioned, that it prevents the hypothermia and same times it can cause the hyperthermia in our babies. As use of polyethylene wraps increases risk of hyperthermia as well. Use of plastic head coverings or hats, stocking knit like caps because of the superior ability to prevent heat loss. A Cochrane meta-analysis concluded that plastic wraps or bags were effective in reducing heat losses in extreme premature infants less than 28 weeks, but not in infants from 28 to 31 weeks of gestation. So it should be used in the babies who are less than 28 weeks of gestation. And other method is providing a thermal mattress. Thermal mattress, when activated, can attain a temperature of 38 to 42 degrees centigrade and maintain it for up to 2 hours. Thermal mattresses are used as an adjunct at the discretion of the stabilizing team to prevent hypothermia in infants born less than 32 weeks of gestation. Exothermic mattress combined with polyethylene wraps may decrease the rate of hypothermia, but risk of hyperthermia increases. So closely monitor the temperature in these babies. Heated humidified gas sport, as we all know that it's our practice that we provide the babies humidified gas to prevent the hypothermia or to maintain normothermia. Heated humidified gas support normothermia by decreasing evaporative loss from respiratory tract epithelium and convection losses that occur in infants inspiring cold air. As soon as possible after birth, the newborn should be placed in a pre-warmed double-walled incubator, as we all have practices in our NICUs, having high air humidity and ambient temperature to mimic the fetal environment. This is another method to prevent the hypothermia. uh, babies in the pre-warmed incubator. Ideally, infant transfer between births should be limited. And whenever feasible, initial resuscitation may occur in convertible isolate with adjustable lid to facilitate access to the infant while limiting subsequent bed transfers and infant exposure. And baby should also be given pre-warmed IV fluid to prevent hypothermia. Cool or room temperature IV fluids may lead to cooling of the neonates, resulting in an increased chance of hypothermia. Although an important measures, IV fluid warmer have not received the due attention it deserves, particularly in extremely premature and extreme low birth weight infants. And second, the other modality is to prevent hypoglycemia in these babies. Preventing hypoglycemia is common in growth restricted. Hypoglycemia, as we all know, that it is more common in growth restricted infants and in premature neonates, as adaptive mechanisms are not fully developed. There is not proper glycogenolysis, and due to inadequate hepatic stores of glycogen, and there is also inadequate gluconeogenesis. 23 to 50% of infants admitted to NICU have one or more episodes of hypoglycemia. Timely establishment for the management, we should do timely establish the intravenous access and initiate of the fluid that contains dextrose in the first few minutes of life is critical in extreme premature and extremely low birth weight infants to avoid hypoglycemia, because we all know that these causes the neurological dysfunction and also causes the impact on the visual acuity. And establishing the peripheral IV access as a bridge. Finally, we should go for the umbilical line placement in these babies, can help avoid hypoglycemia. So we will establish the IV line only just as a bridge to prevent the hypoglycemia meanwhile. And these are definitions of hypoglycemia in neonates by different scientific organization. American Academy of Pediatrics says that the glucose level in first 0 to 4 hours of life should be maintained more than or equal to 40 milligram of deciliter, and after 4 to 24 hours of life it should be maintained more than or equal to 45 milligram deciliter postprandial after feed, and after 48 hours it should be equal or more than 60 milligram per deciliter. And the Pediatric Endocrine Society says that glucose level, where we call hypoglycemia, when the blood glucose level is less than 50 milligram per deciliter in the first 48 hours, and after 48 hours, if it is less than 60 milligram per deciliter. Whereas Academy of Breastfeeding Medicine says that blood glucose level in first 2 hours should be equal or more than 28 milligram per deciliter, and in first 4 to 24 hours it should be more than or equal to 40 milligram per deciliter postprandial, and 48 to 72 hours of life it should be more than and equal to 48 milligram per deciliter postprandial. British Association of Perinatal Medicine says that glucose level between 2 to 24 hours of age should be equal to and more than 45 milligram per deciliter postprandial if symptomatic, if the baby is symptomatic, or equal to or more than 36 milligram per deciliter if asymptomatic, but with the risk factors. Canadian Pediatric Society says that blood glucose level should be between 4 and 24 hours of age should be equal or more than 47 milligram per deciliter postprandial. Swedish national guidelines also says the same levels postprandial, and after 72 hours, equal or after 72 hours, it should be equal to or more than 54 milligram per deciliter. And now we will come to the delivery room respiratory management. Non-invasive ventilation, that is continuous positive airway pressure current ventilation currently recommended in the delivery room by both the Committee on the Fetus and Newborn and the Neonatal Resuscitation Program. Continuous positive airway pressure maintains functional residual capacity, as we all know, of the lung, reduces the need for intubation, and also reduces the need for exogenous surfactant, postnatal corticosteroid requirement, and total ventilator days. Large multi-center trials support the initial use of continuous positive airway pressure in the delivery room within the first 15 minutes after birth, with Cochrane review of 3,201 babies from 24 to 32 weeks of gestation, suggesting a reduction in bronchopulmonary dysplasia and also mortality. Infants with respiratory distress syndrome, early surfactant administration via Ensure method versus later selective surfactant and continued mechanical ventilation was shown to reduce the need for mechanical ventilation and BPD rates. It means that infants with respiratory distress syndrome, if we administer the surfactant early, it reduces the need for the mechanical ventilation and also reduces the risk for the bronchopulmonary dysplasia. And this is the CPAP therapy by the nasal cannula, and surfactant administration by Ensure method, as we all do in our nursery setups. And these are the evidence of the golden hour projects, Reynolds et al. And these are all told before and after the implementation, what are the results. And Reynolds et al. In born neonates who are less than 32 weeks or less than 1,500 grams. Initial golden hour process 2001 to 2017 and revised golden hour 2007 to 2008. Parameter studies increase in the median admission temperature during both the initial and revised process, decreased incidence of retinopathy of prematurity and chronic lung disease in the revised growth golden hour period. And other are Reuters et al. And these are different studies which tell us about that after revised procedure, it decreases the risk of hypothermia, the hypoglycemia, and decreased time to complete the stabilization of these babies after revising the protocols. And at the last, Deleg et al., it tells that 68 bed level IV NICU neonates who are less than 29 weeks decreases the rate of chronic lung disease from 35 to 16.5%. Percentage of infants born less than 28 weeks receiving prophylactic surfactant in the delivery room increased from 88 to 98.1%. And these are timelines for golden hour interventions in our level 3 neonatal ICU. What we expect from the fellow and from our registered nurse, residents, and respiratory therapists. In the pre-delivery time, the delivery by the OPS, if we are notified by the impending delivery that is premature and less than 1,000 grams, what should we do? Review the maternal chart, history, and inform the attendants. And counseling should be done meanwhile. And team consult, and in which we assign the role and huddle with the team and respiratory therapist to assign the roles, notify the unit clerk of impending delivery, discuss the collection of admission, and if cord blood, we will discuss the plan regarding the blood, regarding the cord clamping, and also for cord blood and CBC, blood culture, blood gas type, and Coombs test. And RN's responsibilities are ensure admit preheated incubator should be ready, and delivery room equipment should be available, and checklist should be done, and delivery room temperature should be between 73 to 77 degree Fahrenheit. Turn on radiant warmer and ensure warm blanket, and open the plastic bag and deposit it in the surgical area of the ops and scrub to the scrub nurse. And meanwhile, umbilical line supplies and set up the tray. If not available, second resident remain in NICU for orders should be available. And what's the duty of respiratory therapist? She should check the neopuff, source of oxygen, supplies appropriately sized masks, suction, and ET tubes and blades. And the RT should connect the bubble CPAP heater to the transport shuttle prior to the transport. Ensure appropriate intubation. CPAP supplies are at bedsides. Adjust pressure of the neopuff as we all do in our labor room, and respiratory therapist in the NICU to set up respiratory equipment in the neonatal ICU also. In first 0 to 10 minutes after the delivery of the baby, what should we do? Head of bed resuscitation, lead resuscitation per NRP guidelines. If the baby need resuscitation, then we should do early cord clamping. Otherwise, we will delay till 30 seconds to 180 seconds. Place baby in the plastic bag, assess heart rate, and inform the team until stable. Place skin temperature probe. Make sure silo bag is appropriately covered. Baby hot is in place and available to attend the delivery if additional assistance is needed. And residents should attend the delivery. Place plastic lined hat on the baby and performs neonatal resuscitation under supervision of the fellow. Assign APGAR scores. And what is the duty of the respiratory therapist? She should place the pulse oximeter on the right wrist to check the saturations, preductal saturation. Place the EKG leads as per NRP and adjust the FiO2 to maintain saturations with the target NRP ranges. Maintain the neopuff pressures and ensure adequate uh, respiratory support. And after 10 to 15 minutes, stabilize the infant for transport to the neonatal ICU and update the family. Make sure admission labs are collected from the cord blood. And role of RNs is prepare infants for transport to the neonatal ICU, obtain auxiliary temperature of the baby, confirm the identification bands, and communicate auxiliary temperature to the obstetric registered nurse for documentation. Place identification bonds prior to the transport, bands prior to the transport, and collect the unit clerk to expedite entry of the baby in the system. Enter the weight, begin order, set placement once weight is called from the doctor. Order for a chest x-ray if the baby is intubated. If the infant is intubated, call pharmacy to order for the golden hour, to alert of golden hour admission, so that if we need surfactant and other supplies, we can ask them. And calls weight and other obtained measurements to the NICU. And respiratory therapists should do within 10 to 15 minutes. Make sure ETT position if appropriate, if baby needs the endotracheal intubation. Call for surfactant if the infant is intubated after appropriate approval of the fellow as per unit respiratory guidelines. And in first 15 to 25 minutes, the role of the fellow is prepare for the umbilical line. So umbilical line should be placed within 15 to 25 minutes. Confirm appropriate endotracheal tube line by X-ray, as we all do, or by POCUS. And monitor the blood gases and make necessary adjustment accordingly. And RNs should performs immediate admission assessment. Place a note on the bed, in my golden hour, on bedside remain providers. Administer vitamin K, same time, and erythromycin. Place peripheral IV line, obtain first blood sugar, auxiliary temperature should be performed, and initiate dextrose water to prevent hypoglycemia. And place, and if the baby is still not given IV fluids, so in between 15 to 25 minutes, we should also start the dextrose water. And place OG or NG if the baby accordingly, orogastric tube or nasogastric tube if the baby is on the CPAP. And prepare for the umbilical line if assigned to place. Back up to the place. Patient trigger ventilation may initiate UV and umbilical artery and umbilical venous catheter placement at this stage, or to obtain, if unable to obtain, a peripheral IV access. prepare, and what are the duties of the respiratory therapist? Administer surfactant and perform chest X-ray if indicated. Follow gentle ventilation strategies if involved ventilation is required, if invasive ventilation, is required. And in between 25 to 45 minutes, like a line placement should be done. Obtain ordered labs, type and screen peripheral blood gas, complete blood count, blood culture, not needed if from the cord blood. If already sent from the cord blood, then it is not needed. Prepare central line IV fluids. Call for the chest X-ray if not done up till now. Ensure antibiotics are available if ordered. And also observe, assist with the line placement is the duty of the resident. And respiratory therapist should continue to wean oxygen and run, and also do the first ABG, arterial blood gas or cap blood gas. And in 45 to 55 minutes, the fellow should secure lines following confirmed placement by chest X-ray or point of care ultrasound, perform assessment if needed. And what are the duties of RNs? They should initiate the line fluids and discontinue the peripheral IV fluids, and administer the antibiotics if ordered by the fellow or by the seniors, and administer the indomethacin if appropriate. Secures line following confirmed placement, and meanwhile, the respiratory therapist should perform check ET placement before incubator closure. And in 55 to 60 minutes, the update the family and finish any remaining task which should be done in the golden hour and are left that should be completed. Ensure proper servo and humidity settings, which should be 70 to 80% in the double wall incubators, and obtain temperature and close into incubators, fill out checklist, and these all should be done within the golden hours. Now the strength of the review, and this is a comprehensive and practical summary of the interventions. These also include evidence from large scale quality improvement projects and multi-center trials, and emphasizes multidisciplinary collaborations and implementation strategies. And limitation of the my studies, this is narrative review, lacks systematic methodology, risk of selection bias is also there, may overrepresent positive outcome due to selective inclusion of the studies, and there is also applicability may vary across different resource settings. And what are the clinical implications? Adoption of standardized golden hour protocol improves short-term and long-term outcomes in extremely preterm infants. It also reinforces the need for institutional protocols, ongoing staff education, and data-driven quality improvement. Now, there are few discussion points. How feasible is full implementation of the golden hour in our settings? Where are some barriers like non-availability of proper staff? There is also non-availability of equipment in many of the setups, and staff, if available, they are not properly trained. And could we consider a local quality improvement project to assess our golden hour outcomes? These are the limitations in our setups. This is all from my side, and now discussion, open for discussion.
Thank you, Dr. Majibin. This was wonderful. Thank you for going over the article. I have a comment and I have a question, maybe not directed to you, or maybe as a like to the general audience, I have a question. So my comment
Yes,
is
sir.
that having a protocol of something is way more valuable than not having a protocol, irrespective of the evidence. And the reason I say that, for example, if you have a protocol how to resuscitate a baby, it's way more important than going into nitty-gritty details like, which works, which doesn't work. Because if you don't have a protocol, everybody will do differently, and that does not have synchrony of the team who is going, even if there are two people going for a delivery room resuscitation, for example. So I think one lesson I learned from this is that you have to have certain written guidelines where everybody sink in. So this golden hours, the bigger picture and goal I feel was that, like, you bring people on the same place, like, they're thinking the same in critical moments. And whenever you have such a protocol in place, the best way to improve that protocol is to keep giving the feedback loop. For example, I'm sharing you where I practice. If I have a resuscitation, which we finish the resuscitation, whatever the outcome of that resuscitation is, we always come together and talk to each other. Hey, let's talk to each other. Where did we do well? And the main question we ask, did we do well some of the things we have already written down as a protocol? And we talk about them.
Yes, sir.
Then the
Yes,
second
sir.
thing we do is, what are the things we didn't do well and what we can do next time better? So I think this is one of the way you can actually implement even the golden hour, and you learn as you go. So that is my comment part. And the
Yes,
question
sir.
I have is, because I have to acknowledge I am blind to the resources we have available in Pakistan and the settings we have there, and what kind of resources we have. The question, Mai, is, and maybe the best way is we modify and adjust, as you mentioned in one of the limitations as well. We modify as per our resources and the way you know, our workflow is in Pakistan. But even with that, those limited resources, if you have written down a protocol based on your resources, that is, I feel, way more better than not having, anything in place. So
Yes, sir.
that is what I wanted to say, and it's open to
Yes, sir.
everyone. Yeah.
Yes, sir. So we have also written protocols for the golden hour management in our setup of NICU in the RTH campus, made by Dr. Atar Raza collaboration with other neonatal fellow. And we also try to implement all these protocols, alhamdulillah. Our hospital is one of the state of art hospital in the whole South Punjab. But it's not possible, sir, in children Lahore and in children Multan, where we have very much limited resources. And we have also, because I have seen during my examination preparation, staff is also not properly trained. They also have a written protocols, but due to non-availability of equipments and sometimes non-availability of the proper staff, they cannot proceed with this. And there the babies are mostly referred from the some other tertiary care hospital, whereas we have inborn babies. So we betterly dealt with those babies. We also have a transport incubator, and we try to transport as early as after delivery by following the more or less the protocols which are mentioned here.
As a follow-up question, do you also involve OB nursing staff and the team there, which will also
Yes,
be
sir.
important?
Yes, sir. We are also involved, and our one fellow is fellow or our senior. Our fellow is always on 24 hours on call, and he always present in all deliveries which are high risk deliveries. That is, if the baby is asphyxiated and if the baby is extremely premature, extremely low birth weight babies, it is the duty of the fellow to attend those deliveries.
Thank you, Dr. Majmin. I think I'm gonna let everybody else to chime in, and
With
anyone.
your permission, can I have a comment?
Sure, absolutely.
Yes, thank you. And with the permission of Dr. Ashraf Khurshid as well. I think it
Sure.
was a very nicely presented topic, and we can see all the hard work done in the way the slides were organized and presented, and all the data was given in a systematic way. So thank you very much, Majabin, for setting a good trend. And thank you very much, Dr. Ashraf Khurshid, for supervising and encouraging the fellows. I hope we'll keep on going and improving on this thing. Thank you very much. I think we can let the people from the floor participate in discussion.
Thank you, sir.
Dr. Khoshdil, do you want to comment on anything? Anything you would like to comment on?
Well, so I'm just waiting for the participants if they have got any question or any comment, if they want to add anything. So if there is no comment or
How
if there is
can I ask
question.
one question? How practical is the use of plastic bag in Pakistan? It's something very cheap, but
So
how practical it is.
sir, it's practical. So we have inborn babies and we used in our setup.
So, and where do you get these plastic bags? They have to be sterilized.
Yes, sir. So we ask our pharmacy, they arrange the sterilized bags. So our hospital is free of cost, and even surfactant does not cost to the attendants. It also, whole things are arranged by the hospital itself.
We know, and this hospital is a blessing. It
Yes, sir.
is a very, very good care at zero cost to the patient.
Yes, sir.
We are also talking about the common man in Pakistan out of Indus Hospital. What happens there, where majority of the patients would go?
Sir,
What
I
would
would
you
like to
advise
add,
them to do? Yes, please.
Sir, Sir, I think as you said that the plastic and the polythene bag should be sterilized. Sir. So what we are using and what I have practiced, sir, we have got certain plastic gowns which which the OT staff is using in the OT rooms. They are also sterilized, sir. So in many setups, many a times the proper plastic polythene bags are not available, and if they are available, they are not sterilized. So, but in the OT and the labor room, those polythene, the plastic gowns are available and they are sterilized. They are pre-packed and pre-sterilized, and they are basically for the OT staff. So I have always, and most of the time, I have used those plastic bags for resuscitating the extremely low birth weight baby. So whenever a baby who is less than 28 weeks of gestation, so I will always wrap up that baby in those what we call as the plastic wraps, and we bring the baby and we resuscitate the baby in that. So just for the for my colleagues working in Pakistan, so some of them might not be knowing that even we can use those plastic coverings which the OT people are using, so they can use for wrapping the babies on those sheets as well. They are also very effective, sir, for maintaining temperature, sir.
Yes, sir. It's a good suggestion.
We use the warm towels, which we used to use in old days before the concept of this plastic wraps came.
Sir, towel the issue ये है, sir. The problem is with that when it gets wet, sir. So then it has got small holes, and then the air can pass through it, and that can cause some sort of then convection and evaporation as
Yeah.
well. But the plastic, the advantage of using the plastic is that even if it gets wet, because you do not need to dry the baby before wrapping the plastic wrap. So I think that evaporation and the convection will not be a problem with the use of the plastic wrap. So I think that's why the towels are no more used and recommended, sir, and will not be good for maintaining temperatures.
And I will add on to that, I will also be worried about skin integrity, especially on very premature babies with, sometimes it breaks very easily in my experience, especially the smaller babies, extremely premature babies. I have to, commend all of you who are working in Pakistan. Trust me, you guys are doing really great service. And the reason I say that, I commend that you guys, work against a lot of barriers. I visited Pakistan and I saw how the ground reality is. And despite having limited resources, you guys are doing amazing job. So I want to comment on that.
Sab jihadi and
Seriously, I think, and I always feel that I think the real giving back to the system which produced us is the people who stayed back home, and they're paying back. So don't
agree
feel
with that.
like,
Yes.
yeah. And the reason I'm saying is a lot of time I think you guys feel like, okay, maybe we should have left the country, but looking at the bigger picture, you guys are the real heroes. And then I have to say that again. So please, make us proud and keep doing what you're doing.
There is no doubt. I agree with that,
Arshad,
and I support your comments.
Thank you, sir.
Dr.
Yes, please.
Sajad, can I say something?
Yes,
Sajid here.
please, please.
Yeah. Okay, I think what we need to think about it is a mandatory requirement to have a plastic bag, and it should be clean, because what my understanding is and what we do in our setup, it should be a plastic which is non-toxic, it should be food grade, it should be clean. And what we do is that it's available at the store, which is got a food grade plastic bag. You have seen one with the zippers. So they come in different sizes and you can easily use them. They are pretty clean, but I think it's very difficult to digest this thing that they must be sterilized. It's mentioned somewhere in the NRP that plastic bags should be sterilized, because what my understanding is, it should be clean, non-toxic, food grade, clear bag. This is what we are doing for the last 8-9 years in our setup. Number one. Number two, I think what has been mentioned in this whole golden hour, which we did in the UK as well, practically one has to be very bold. Even I am just trying my best to convince the gynecologist. My code is wait a minute. Wait a minute is 60 seconds, isn't it? So we say just wait a minute. So I spent 9 years over here, even going to the theater for sick premature babies, standing there in front of the gynecologist and telling them, could you please wait a minute? It needs immense, stamina to say that, and there are a lot of problems. One thing which I did is that when you're moving a baby from the bed, from the operation theater or labor ward, that should always be moved in a cot. No one should pick the baby, especially the sporting staff. They pick the baby and their hands are not clean. That should be by the midwives, and they should put the baby in the cot and just move the cot to the resuscitator, because maybe 1 in 100, sometimes you can slip, you can trip, you can fall, baby will fall down. That creates a lot of problems, legal, ethical issues as well. So that's the other thing which we are doing over here in this resuscitation. Moreover, for the as far as we have talked about resuscitators, the most important thing is how many of the people working in Pakistan that they've got resuscitator in the NICU, in the theater or labor room, they've got blended oxygen. That's a very key question. In this, we'll have Shifa International and the rest of the people, but the places where I, went in the last 9 years, almost 90%, they do not have a blended oxygen over there. They do not have the SAS monitor. So I think journey of 1,000 miles starts with a single step. Where there's a will, there's a way. There's always a light at the end of the tunnel. And that's the reason I'm very glad that Qatar is sending 2 of his postgrads. Last year they sent 2, and tomorrow 2 are coming to my center. They will join at 8:30. They will stay here for 3 days. They will book room in the hotels, and we'll try to facilitate them, because we are doing in our NICU head scans, lung scans. We are doing echoes. We are doing focus in abdo scans as well. So this is from my side. I thought I will just add few points in this presentation.
Thank you, Dr. Sajid Nazir from Waken. And
Yes,
I'm
yes,
sure,
yes.
yes, I know that. You are well known for the innovations you have done in your unit, and you have been leading the neonatologists by your personal examples. You've done a wonderful job. Thank you very much.
I do have a
Thank you.
question by Dr. Nizami. I want to know about the cutoff blood sugar in your setup. I can mention about my practice where I am at Nationwide. We use AEP cutoffs like less than 40, if like the first 4 hours, and then 4 to 24 hours is 45, and then 60 after that. I'm not sure about what about your place, Dr. Majubin?
Sir, same. In first 4 hours, we use to cut off value of 40, and 4 to 24 hours, we use 45, and after that, 60, more than 60.
And 45 is round about equal to 2.6 millimoles.
Yes, sir.
Okay, yeah.
Yes, sir.
And another question from the chat box: can polyethylene bag be used in less than 32 weeks, 1,500 grams, or should it strictly be limited to less than 28 weeks? We use in our practice less than 31 weeks, I know, but I don't think, as I mentioned before, I think that you can devise your own protocol depending on the limitation. That is my comment on it. But
Doctor, can I say something?
yes, please go ahead.
I think, there was a time when there was a, experience-based medicine, then we moved to evidence-based medicine in 1990s, and then now we have CM-based and personalized medicine. So if in a theater where in Pakistan where there is no temperature control and it's very cold, does this 28-30 apply? I think it all depends upon the adaptability. If you look at the environment, it's very cold, these tiny babies. Neonatology is the one thing where it starts with TABC. Rest of the world, adults, they say ABCD. We start from TABC. So I think what we do is it all depends upon your theater and labor room, all these temperatures. So if it is even 31, 32 weeker and it's too cold, you can just put it in the bag. What's the problem for 31, 32?
Yeah. Thank you,
I
Doctor.
think that's a very important point, and we need to talk to our obstetric colleagues about the delivery room temperature and the OR temperature. It's very simple, but they need to come to this understanding.
The next question is, can plastic bags for food preservation be used for this purpose? Any comment on that?
I think this question is not clear. They have to rephrase it.
Okay.
Sir, I think probably they want to ask you जो simple shopper नहीं होते थैले.
No. That's why I'm saying that's a different thing. That's why I'm saying.
वो तो different
That's
है,
why I'm saying
sterilized
that they are
सब
very.
issue है.
If you go to Arshad, if you go to the market where people they have got these bottles for the Abu Zamzam and Hajj and they have the bags. They have got plenty of different bags. When you tell them, I want to have a food grade plastic, they will tell you that's costly because that's 3-4 times costly. So maybe one bag will cost you 30 rupees. So what we do is that in our resuscitation bag, the box which goes to the theater is always 1 or 2 plastic that's mandatory. So they are here because you keep them on the resuscitator. People they mix up different things and that can get infected. So it's better to keep it there. So it's a food grade plastic. It's not a simple polythene, this shopping bag. That is very fragile, that is very sticky, This food grade plastic is comparatively of a better quality.
I think I don't have any more questions. Anything else anyone wants to comment on?
I think what Safdar I will say is that what I've learned in this last 9 years, I think we should spend time and spend some money on the blenders, and NICU should be 100% blended oxygen. No matter when you bring the baby from the theater, then you can just put the baby on resuscitator, that should be blended. And even now, because I'm doing cardiology as well, and the difficult thing for me is to send babies. Sometimes few babies they're stuck on very low flow oxygen. So how you can send them to give them 100% oxygen when you have started oral plastin and other things as well. So from America, through some resources, I got some microflow meters. And these microflow meters they get fixed with the the compressed cylinders. For example, if you've got a medium-sized cylinder or a lesser volume cylinder, which parents can then take to the home. So in 9 years, we have practiced a lot. So these microflow cylinders, when you fix on them, you just give them 0.02, 0.04, something like that. Sometimes they stuck on little reduction. But in the NICU, on every incubator, because in Pakistan, the blended option is given through ventilator or a proper CPAP, DUPAP, where you've got the dial and you can just maneuver it. But they are simple blenders, and even sometimes the ventilators which are out of order, you can just get rid of them and you can use their parts here, their blender system as well. So it is a collaboration with the electromedical, hand in hand you can create these gadgets. And recently I have done one innovation which I'm just working on that. I have copied, you have seen this NeoBar and NeoFit. Have you seen that? You must be aware of that NeoBar, NeoFit. So
Yes.
through I have just, because I brought them from UK 10 years ago, and with the time they're gone. So in last 6 months, I've tried to create those. Still, that is not properly materialized, but Alhamdulillah, I managed to create that plastic bit. Only the simple bit which sticks with the cheeks. That's the very problem. We are struggling on that. But if that is done, but in my NICU, I never put a baby on ET without this ET holder. I always put ET holder that makes the life of the nurse is very easy. So it's very important thing which we can do. So I think if we do blender, because most of the babies when they come to me from different hospitals as well, even in the ambulances, 100% oxygen, and 100% oxygen is a very risky thing. And I will just sum up. The day before yesterday, baby was brought to me, and they were sending the baby on a home oxygen. And when I did the echo, baby had a large VSD. And they said that the previous center, they were telling that this baby's lungs are wet and this baby will take time. So how 100% oxygen giving to my baby going home will get rid of these wet lungs? You are increasing left to right shunt. So I think the minimum message is that we have to work in this country to get rid of this toxicity of the oxygen and spend time on the blenders. And even in the bigger hospitals in the Pakistan, if you visit, you will not find this freely available, and it can be done easily. This is my one important message.
And that brings me to this question, that how is the ROP situation in Pakistan? Is it?
I just give you one example. One of my registrar, he had twins, okay, and even I told him that could you please get these babies checked? And now he's in Ireland. His baby is being treated in Ireland. So interestingly, he overlooked that thing. And one of the baby, even I told him, because we are working with Al Shifa Hospital, they have got a pediatric ophthalmology now for the last couple of years, and Shifa International, they have got one of the professors who is doing that. So we have created a form. So any baby who is less than 2 kg in our country or 32 weeks, we send them. And we have not many, but the people who had this situation, whole family is, very, very difficult situation when their baby's eyes are lost. And that family was really disturbed. Finally, they got some job in Ireland. So, their child is being dealt there, but they lost the eye. So we are trying our best to send these babies over there. But why don't we treat the cause? So we know it's a multifactorial, but one thing which is very rampant in our country is the 100% oxygen. When the baby is born, baby's tachypnic is TTN, whatever, is 100% FiO2, and 100% is always very cold. If you touch your hand with the flow meter, when you even put the water, you will see it's cold. So I think blender is very important. If we blend, maybe we have a minimum this ROP. And for ROP in Pindi and Islamabad, we have to find ways. So like Shifa International is costlier. You can send them to the Al Shifa Hospital, which is a trust hospital. Similarly, in Lahore, Karachi, everywhere, we have got people who can facilitate us. But I think prevention is better than cure. So we have to go for this oxygen bit as well.
And I cannot agree more on that. I think I usually used to say this as just to scare some people who were using oxygen like a candy, that there was an experiment they did. They gave 100% oxygen to the mice for 10 days, like 100%. And many of them, like most of them, they didn't survive. So it's a toxic thing, and we have to be very careful about it. But hopefully, we will keep trying to find ways how we can chime in, how we can do things differently, hopefully in future.
I think the point Dr. Sajid Azir is raising is very important. The oxygen and respiratory therapy in Pakistan. The basic concepts are not yet being understood by the people, even in those working in pediatrics, as he's mentioning about the concept of FiO2. You don't have to give 100% oxygen. You have to have a blender. But to find a blender, to use a blender, and to convince the people to use a blender is a very uphill task. And again, the oxygen, as Sajid is saying, is cold. It has to be heated. It has to be humidified, whether it is oxygen or it is the oxygen air mixture and whatever FiO2 it is. So to get a humidifier and make it a part of the standard care is also a very important part of the respiratory care. So this very basic concept needs to be brought into the day-to-day education in our NICUs in Pakistan. And this actually is a very serious issue.
Yeah, this Fisher and Paykel humidifier, that you can get it for 1 lakh rupees. It's very costly anyway if you get it, but it's a 1 lakh rupees. So people think that when the oxygen air, if you just pass it through the water, is humidified, but it's never hot. So you have to make it hot.
That's not even humidified.
But they think that's it's a crude humidification type of.
This is what I was pointing out too, that the right concepts need to be taught and they need to be assimilated by the seniors and implemented.
Yeah.
I'm going to take one more question from Dr. Naila. What is your understanding of opening 1 liter oxygen, providing 25% oxygen, and adding another 4% with each liter of oxygen? Dr. Naila, would you elaborate? Can you unmute, and if possible?
You hear me?
Yes, we can hear you.
Assalamu alaikum. Actually, I go for NRP teaching across Pakistan and most of the time in government setups. And I come across this understanding of people. As you were talking about the blender, so I thought I should spread this message from this forum that people in most of the government setups say this, that if we are giving 100% oxygen at 1 liter, it's just giving 21%. And with increasing 1 liter of oxygen, we are adding just 4%. Like if you open the oxygen at 2 liters, you are giving at 29% oxygen. I try to rectify them, and most of the time people don't agree with me. They say that it is written in the literature.
Are you talking about oxygen in the incubator?
No. It's about the central oxygen supply, or maybe from a cylinder which is providing 100% oxygen.
Can I
Where
reply
is the
to it?
mix? Yes, please.
Actually, this is the concept came in Pakistan from adult medicine. Adults, because they have got bigger lungs, bigger oral cavity, and when you give a 1 liter oxygen to a 70-kilo person, this is a mixture from the air as well. That's a different concept, and unfortunately, that is being utilized in neonatology. In neonatology, if you give 80 ml of oxygen per kg, for example, if the baby is 3 kg and 80 multiplied by 3 is 240, so almost 0.25 liters of 100% oxygen gives FiO2 of almost 40%. So if for a 3 kilo baby, you give 1 liter of oxygen, it's almost 100% oxygen, because only 0.25 gives 40%. So this concept from the adult medicine, where they have got different anatomy, their size is big, their lungs are big, their breathing rate and the tidal volume, everything is different. So I think that thing is being replicated in neonatology, which doesn't work. That's a very risky concept.
This means giving through the nasal cannula.
Yes, yes,
Yeah, they're saying that if you give 1 liter, it is not much. If you give 2 liter, 3 liter, in neonatology, you give 4-5 liters. In adults, you can put a face mask, give 20 liters to a 70 kg person. That's a different thing. So I think here we are mixing the adult concept and we are modifying it, and not only applying in children. In bigger children, 5, 10, 14 years might work, but these are tiny babies of 1 to 2 kg. Size doesn't matter here.
Thank you, Dr. Sajid. I just wanted to spread this concept from this forum because I find it on multiple people say this, very senior people say this, that it's okay to give 3-4 liter. We are just giving 30% or 40%, and they have this.
I just want to say important thing which I learned by combining the neonatology and cardiology is, if you've got a baby, you put the baby on, let's say, 3 liter of 100% oxygen. How you are going to wean the baby? What people do is they reduce the flow. There is a baby who needs more flow and less of FiO2. So what you do is you reduce the flow to 2 liters or 1 liter, and then you again start, babies start breathing again, and then you keep on shuttling between the two. If you keep the very same baby on, let's say, 3 liters, and you reduce the FiO2 from 60, 40, 30, you will realize that by giving 3 liters, because flow is a pressure. When you give flow, whether there is the air, whether there is the oxygen, flow is flow, it will generate a pressure. So when you give 3-4 liters, it is creating a pressure, but you have got the control through a knob on the oxygen. And oxygen is a toxicity. So what you do is you reduce the oxygen first and bring it to 40% or 30%, and then you reduce the flow. But when the very same baby is in the hospitals, there is no blender, they give the 100% oxygen. Initially, everything is hunky-dory, 100% sad, they are very happy. And then they try to wean down, and the baby says, no, man, I need more flow. To include cover the dead space and FRC and other blah, blah, blah. But what happened is that they keep on reducing flow, and then they say baby is always stuck with coming up and down. So the bottom line is, one is flow, one is the FiO2. You should have a blender, use the flow, which is not as generous as the FiO2, reduce the FiO2 first and then the flow.
I think that is very right what you are saying, Dr. Sajid Nazir. And one other important thing which we need to let the people understand clearly is the oxygen saturation limits. As you have mentioned, some people are very happy with the 100% oxygen. But we don't want 100% saturation. There are limits and there are consequences of having hyperoxia as well. So we need to let the people understand that there are normal saturation limits, and these must be followed very religiously.
Yes, that's true.
Sir, I also have a question, sir. Sir, like at times we get these very low birth weight babies, 1 kg, 1100 grams babies, and at times they are on room air and their saturation is 100%. So what are the chances of these babies getting, if they are not getting any oxygen, but their
100%
saturation
saturation, yeah. The
in
saturation
air?
limits are, yes, saturation limits are for oxygen, not for room air. If a baby is in room air and is saturating 100%, he is not at any risk of ROP or any other oxygen toxicity. 21% is normal.
But the pathophysiology will be the same, sir.
Arshad, this is a
No.
very good question, and I think Professor Sajad has rightly said. This is another misconception. Another misconception. Oxygen is a medicine. When you take a medicine, it has got effect. If a baby on its own, through the respiratory drive, making the saturations on the monitor 98, 99, 90%, That is the room air. That's not a problem. You cannot control that. But what you can control is your oxygen to the FiO2. So when we give one baby 100% oxygen and the sats are 98, and when we give other baby just room air option and sats are 98, there's a big difference, because in the first baby, we have given our intervention, we have given a medicine which has got the limit, and other babies in the room air, there are no prongs, baby is self-saturation, maintaining the saturation, that's a totally different thing. So that baby is not on risk as compared to the one in which we have gone down, done a humanly intervention with the medicine. What do you think, Professor Shah? Is it okay?
And I will add on to that, I have not come across any baby who actually did not require any intervention from the birth, even being smaller size to 12 ROP, because we track all of them. It's usually the baby who required some oxygen need in the beginning, usually intubated, who required high oxygen, was on vent for a long time and progressed to the high stages of ROP. So going back to your question, Dr. Hushdul, it's a great question, but it's the room air and the saturation on room air, even being 100% all the time, it usually does not increase the risk.
Thank you, sir.
And actually, I will add another aspect to it, and that will be counterintuitive to what all we have been saying right now. Some of the literature actually suggests that after certain time periods, intermittent hypoxia, which actually causes more ROP progression than actually being like, fine on saturation side on the higher end. So the way this pathophysiology works is actually changes. So in the beginning, it's the oxygen when the baby is born, but later on, it's also intermittent hypoxia. You actually don't want, that's why we change our saturation targets also when the baby is bigger. So I think there are a lot of probably unknown in that area as well. I hope this also helps to answer your question.
Sir, thank you, sir.
Yeah, I think this is a very important topic, and I think we should have a separate session and a presentation on this oxygen therapy and saturation limits in this forum.
Okay, I think we're running out of our time. This was a wonderful activity today. I appreciate everyone who joined, and I'm going to remind you that I'm also going to work on the video recording. We will edit it and we will share in our WhatsApp group. And if someone missed it, they can also, listen to the talk. Thank you so much, everybody.
Thank you very much, sir.
Thank you very much, Mr. President, for your help and support. You have made it happen.
My pleasure.
It's happening because of your dedication and your love and care. Thank you very much. And thank you, Dr. Arshad and Dr. Mahjabin.
Thank you,
Thank
sir.
you, sir.
You have created a very good, rather a difficult example for the others. We hope they will follow, inshallah. Thank you very much. Thank you.
Thank you,
Shukran.
sir.
Assalamu alaikum. Assalamu alaikum.
Walaikum salam.